for the lovely introduction, and thank you so much for the invite to this session. I heard the previous talk, very nice talk, but I'd just like to make a comment that immunotherapy in MSS patients with CRC metastatic should not be considered as of now for clinical practice, because the data is really not that great for it. But I'll come to something I think a little bit more exciting, which has a lot more data. It's ctDNA-based MRD testing in CRC. Now, we've made some really significant progress in the realm of colorectal cancers, and I've just sort of summarized it into 3 main points. In the metastatic setting, we are now using a biomarker and a phenotypic approach that has actually improved prognostic outcome in our patients. We know in patients with stage 3 colon cancer, shorter duration of chemotherapy is equivalent to longer duration of chemotherapy. We've had a lot of data regarding that. And in patients with rectal cancer, a total neoadjuvant approach has certainly improved prognostic outcome. And especially in those MSI high patients, a non-operative approach is certainly evolving and has become a feasible option. But what are our current challenges as community oncologists in the clinic? Well, when you look at the basic overview of colon cancer management, at least in the non-metastatic setting, in those patients with stage 2 colon cancer, we always ask the question, who needs chemotherapy? And we have some basic criteria to try and determine chemotherapy, including those patients who've got poor prognostic factors such as perforation, less lymph nodes that are looked at, that's less than 12 lymph nodes that are harvested, or poorly differentiated carcinomas, lymphovascular invasion, and so on and so forth. But they aren't very accurate, and the maximal benefit that you can get with chemotherapy in these patients at 10 years is less than 5%. And then in those patients who have stage 3 colon cancer, we ask ourselves the question, does everyone require chemotherapy? Should we be giving 3 versus 6 months of chemotherapy? And should we be using single agent versus doublet versus triplet? And in the metastatic session, those patients with stage 4 colon cancer, where you are able to do surgery and you can render them NED, can we potentially cure these patients? Now, in the realm of rectal cancer, we also have asked ourselves the question, in those patients with low-risk stage 2 cancers, or those patients with high-risk stage 2, stage 3 cancers who've undergone chemoradiation therapy and surgery, again, who needs adjuvant chemotherapy? And in those patients who are high-risk stage 2 or stage 3 rectal cancers, can we potentially avoid surgery and enter a non-operative management program for these patients? And can ctDNA detection of MRD actually help us in that? And then, of course, those stage 4 de novo patients where you render them NED, can we potentially cure them? So many questions where we don't have the answers to these questions, where we're trying to find to potentially find those patients where we could potentially give them chemotherapy and try and improve prognostic outcome, really asking the question, what is the role of ctDNA in MRD in the management of early stage colon cancer? But the first question we ask ourselves is, what in fact is MRD? Well, we know that MRD is minimal residual disease. Chest X-ray can detect up to 10 to the power of 9 cancer cells. CT scan detects 10 to the power of 7 cancer cells. And we know that ctDNA, you don't actually see anything on imaging. It's 10 to the power of 5 cancer cells. And so the real definition of MRD is defined as a detection of ctDNA with no other clinical evidence of disease recurrence in patients who have completed all potentially curative therapies. And really, it's this part of that algorithm of our patients. So we know that looking at plasma cell-free DNA has actually told us that when we're detecting it 30 days post-op in our patients with colorectal cancer, it's associated with 7 times the likelihood to relapse. When it is post-adjuvant chemotherapy and ctDNA positive, it's 17 times the likelihood to relapse. And in those patients who have persistent ctDNA positive disease, as you do longitudinal follow-up, 43 times likely to relapse in those patients. We also know that in terms of risk stratification in our patients with stage 2 disease, those who are ctDNA negative versus positive do a lot better. And so the ctDNA positive group in stage 2, do they actually require chemotherapy? And in our stage 3 patients, those who are ctDNA negative, where they do so well, do they even require adjuvant chemotherapy to begin with? Now, there's been so many methods of minimal residual disease detection that has actually come into play. Carcinoembryonic antigen is actually one method. Circulating tumor cells is another method. But the most sensitive and specific method that we'll be talking about is actually circulating tumor DNA, which has actually been shown to be one of the most important prognostic factors for recurrence compared to all those other factors that we typically tend to look at, such as T stage, N stage, tumor location, histological differentiation, lymphovascular invasion, and even post-operative CEA, ctDNA trumps that in terms of being a prognostic factor for recurrence of disease. Now, we've used two main methods for looking at MRD. It's either a tumor-informed method, where we need tissue from the patient. That tissue is sequenced to make a custom panel of limited genes for individual patients. We then use a PCR-based assays used to detect the presence of ctDNA, or we use a plasma-only platform where only blood is required, where we use methylation and epigenomic markers for the presence of molecular markers or MRD after curative intent surgery. And this is one of the plasma-only platforms, which is known as Guardant Reveal, where it looks at both genomic as well as methylation markers. And this is important when you're looking at plasma-only methods, because we know that when we're looking at ctDNA, these levels can be actually very low in patients who are post-op, where there's not a lot of somatic mutations to actually detect, and you may actually not be able to detect those MRDs that you're actually looking for. So we then incorporate methylation markers, because we know that abnormal DNA methylation is common in colorectal cancers and can affect thousands of sites. It often occurs early and can predate the development of actually somatic mutations. And it provides more signals to detect more tumor DNA, and that elevates the sensitivity, making it almost equivalent to that what we see in tumor-informed methods. Now, we know that there are certain differences between tumor-informed and tumor non-informed, which is the plasma-based assays, where tumor testing is not needed in the tumor-uninformed assay. We know that the turnaround time is so much longer in the tumor-informed assays, can be anywhere between 4 to 6 weeks, which can cause problems. We also know that in terms of post-operative timing, in terms of detection, is 2 to 6 weeks in tumor-informed versus more than 4 weeks in the tumor non-informed assays, and they're both commercially available for use. Now, let's look at some of the clinical data that's supporting the testing for MRD in colon cancer. Now, there's been a lot of data, and I sort of filtered it down, but I think the basic question that all the data tends to ask, in terms of the question is trying to ask, is adjuvant therapy in terms of chemotherapy actually needed, irrespective of the stage of the patient, be it stage 2, 3, or 4? So one of the first studies actually to look at this question using a tumor non-informed assay, it's a plasma-only assay looking at Guardant Reveal, was published last year in Clinical Cancer Research. A very interesting study taking 252 prospective samples from 103 patients with colorectal cancers who had undergone curative intent surgery. So they had stage 1 all the way to stage 4 disease. Those patients with stage 4 disease had curative intent surgery as well. And what you see from the landmark analysis is those patients who did not have ctDNA detected actually did a lot better than those patients who had ctDNA positive disease. You can see in terms of the sensitivity, it was about 55.6%. In terms of specificity, 100%. When you're looking at those patients who had ctDNA positive disease, they had, these were about 15 patients, and all of them recurred, resulting in a positive predictive value of almost 100% and a negative predictive value of 75.5%, something that we've seen also with tumor-informed assays. Now, when you're looking at the longitudinal follow-up of these patients, in the landmark analysis, the sensitivity was 55.6%. And when you started testing longitudinally, you can see that the sensitivity actually increased to 69% and then to 90% in that surveillance part where you're actually looking at multiple samples. Then when you look at incorporating both the genomic, epigenomic, and components of the plasma-only analysis, you can see that the minute you started incorporating both genomic as well as epigenomic markers, you can see that that sensitivity actually goes up in the surveillance component to 90% and the longitudinal component to 69%. So you really needed both components to increase the sensitivity of the assay. We also saw the results of the Cosmos CRC study. This was presented at ASCO GI earlier this year and then at the Japanese Oncology Society. This was a study that took about 100 patients with stage 2 and 3 colorectal cancer patients. They used the Guardant Reveal assay, again, a plasma-informed assay, where you can see that in terms of epigenomic signals were detected more frequently than the genomic signals post-operatively. And to increase the sensitivity, you really needed to have both genomic as well as epigenomic signals. And you can see that post-op at 28 days, if you were ctDNA positive, you had a 1-year DFS of 83%, while if you were ctDNA negative in terms of MRD, it was 1-year DFS of 93%. We also saw another study that was presented at ASCO GI earlier this year. This was the Circulate Japan project, and this looks at specifically at the Galaxy sub-study of this project. This is a big study that's currently undergoing in Japan. It's an observational study taking patients with colorectal cancer stage 1 to stage 4 who had undergone either an R0 or R1 resection. These patients had to have post-op ctDNA detected at 1 month. They used a tumor-informed approach over here. And in that Galaxy subcomponent of the study, you can see they did prospectively a number of follow-up ctDNA analysis. Very interesting results. When you look at the overall population, again, if you're ctDNA negative post-op at 4 weeks, you do a lot better than if you're ctDNA positive at 4 weeks. And you can see that in terms of disease-free survival. In the ctDNA negative population, interestingly, when you looked at that high-risk cohort of stage 2 and 3, they do almost exactly the same. So there didn't seem to be any significant benefit to adding adjuvant chemotherapy in that ctDNA negative cohort in that high-risk stage 2, stage 3 cohort. Then when you looked at patients who had ctDNA positive disease, in those patients with stage 2, 3, or 4 disease, you can see that those patients who actually get chemotherapy, they actually do a lot better than if they don't get chemotherapy. So MRD positive patients actually benefit significantly from adjuvant chemotherapy, regardless of the stage of disease. They also looked at the ctDNA dynamics from post-op 4 weeks to 12 weeks, and you can see that those patients who went from being positive to negative actually did very, very well. This was 68% of patients who got adjuvant chemotherapy treated patients cumulatively cleared their ctDNA by week 24 and had significantly better outcomes compared to patients who actually remained ctDNA positive. Now, this was very interesting. I'll just go back one slide. 68% actually cleared with adjuvant chemotherapy, and this is not what we've seen from previous studies. You can see that the clearance that we saw in Galaxy was almost 3 times higher than what we've seen in these smaller retrospective studies that have actually been published in the past. So one of the questions that's come up is, using ctDNA, is there an opportunity to actually escalate chemotherapy? Now, this was a very interesting subgroup analysis that was presented at ESMO 2019 that comes from the IDEA France study. And as you know, in the IDEA France study, they looked at 3 months versus 6 months of chemotherapy in patients with stage 3 colorectal cancers. And what they essentially did was they went back and they looked at the ctDNA that was collected and looked at that MRD. And interestingly, they saw that 3 months of chemotherapy was associated with poor outcome in patients with ctDNA positive disease, both in the low and the high risk groups, suggesting that perhaps 6 months was even better than 3 months when you're looking at that ctDNA positive patients asking the question, should we be escalating chemotherapy in those patients? This was another study that was published earlier this year in Clinical Cancer Research that I think asked also an important question about persistent ctDNA clearance. What they essentially showed was that only those patients with sustained ctDNA clearance over time didn't experience a recurrence. It wasn't important only to clear the ctDNA, you had to be persistently cleared, so indicating the importance of doing those follow-up ctDNAs. It's also important to note that in this particular study, they did serial ctDNA assessments and found that there were two groups of patients. One group of patients that actually had a fast growing tumors where the MRD was rapidly growing at almost 143% per month, while you had those slow ctDNA patients where it was actually increasing at about 25% per month, again suggesting that we need to be looking at these two groups separately in terms of how we're going to approach them. Then finally, the blockbuster trial that we all saw at ASCO this year, and that was the dynamic study. The dynamic study, the objective of the study was to assess whether a ctDNA guided approach could reduce the use of adjuvant chemotherapy in those patients with stage 2 colon cancer, and they used a tumor-informed approach here. These patients had to have undergone an R0 resection. The plasma collections was at 4 and 7 weeks post-op. They had two groups of patients, the standard management patients where adjuvant therapy was given based on clinical criteria, and the CT-guided management patients where patients who were ctDNA positive received adjuvant chemotherapy and ctDNA negative did not receive any therapy apart from observation. The primary endpoint was relapse-free survival. And what was interesting was, before you actually saw the results of the study, what was interesting was that patients who had a CT-guided approach actually had more oxaliplatin-based therapy if they had ctDNA positive disease compared to those who had standard management. So I thought that was very interesting. And you can see even the proportion of adjuvant chemotherapy was higher in the standard management versus a ctDNA guided approach. When you looked at the recurrence-free survival between the two approaches of ctDNA guided and standard, you can see that the 2-year recurrence-free survival was exactly the same. And when you look specifically at those patients who were ctDNA positive versus negative, not surprising, ctDNA positive patients tended to do worse compared to ctDNA negative patients. And when you looked at clinical risk as well as T stage, you can see that patients with higher clinical risk and T stage, irrespective of their ctDNA, tended to do worse than those patients with lower risk. So really asking the question, should we consider clinical risk and T stage when considering omitting therapy in the ctDNA negative group of patients? So in my last two final slides, what do we know about ctDNA in 2022? I think this is what summarizes it. The persistent presence of ctDNA after surgical resection is the strongest poor prognostic factor we have ever identified. And I think it is more important than T or N stage, but we can't eliminate T or N stage. We know that adjuvant therapy can decrease the likelihood for cancer recurrence in ctDNA positive cases, and ctDNA kinetic is early marker of treatment response. But what don't we know about ctDNA in 2022? I think these are some of the questions that we're going to have to ask. Can we use sequential ctDNA monitoring and only use adjuvant chemotherapy when the ctDNA test turns positive? And would this compromise the outcome of patients? Can we potentially de-escalate intensity or duration of adjuvant therapy in ctDNA negative cases? And will ctDNA positive cases benefit from an escalation of the intensity or duration of adjuvant therapy? Can perhaps molecular targeted approaches be helpful in these cases? Can we forego routine surveillance scannings in lieu of serial ctDNA monitoring? It certainly will be less radiation exposure for our patients. And can ctDNA conversion be used as an endpoint for adjuvant trials? Can ctDNA help predict or define the benefit or lack of benefit of local therapies? And finally, can ctDNA help us define the duration of immunotherapy when patients have reached a state of NED in that metastatic setting? I think these are questions that we will need to answer, and but apart from that, we won't be able to wait for those 5 to 10 years that it'll take all these other trials to come up. I think as a consensus, we will have to manage our patients well in the clinic and incorporate ctDNA at least in those stage 2 patients where we know we could potentially remove the need for chemotherapy. So thank you very much.